Well, thanks for that introduction. I think some of that stuff was pulled off some old website. I actually practice in Orlando, Florida. I don't do anything with lymph nodes. I purely do body contouring and aesthetics. My talk is about I picked upper body contouring and how to combine some surgeries together, but still get good outcomes. And I might run through this a little bit quickly because I've got a patient in the OR. So I'm a consultant for Vaser Solta, although I don't really talk about that during this talk, so it shouldn't be an issue. So today I want to go over identify patients who benefit from upper body contouring, discuss how to mark and perform breasts in combination with an upper back lift or bra line lift, talk about scar and my evolution, with where I place my scar, and then I'm not sure we'll get to the last point. I think I might have cut that out of this talk because it was getting a bit long. But maybe we can have a discussion about brachioplasty in combination. So I did a fellowship with Dr. Peter Rubin and Jeffrey Gusinoff at UPMC about 7 years ago now, and I've been employed at Advent Health for about 6 years now in Orlando, Florida. These are my academics and education. Again, I'm a consultant for Vaser. So some quick pre-op considerations, make sure patients have a stable weight. We want to make sure we get labs, especially humans. I do all my surgeries in a hospital, so I'm not limited by time. But I try to limit my in-OR time to 9 hours. So that includes time I'm going to sleep, waking up, and then any flipping if we have to do that. Because I'm in the OR, we're not bound by the state laws of outpatient surgery. But if I do more than 5 liters of lipo in combination with any excisional procedure, I'll keep the patient overnight. And then in general, patients, we have a couple of weeks off. We recommend getting some supplies. And then we do use ERAS protocol. So we use Exparel for all our patients to help decrease narcotic usage and make them more comfortable. So one of the things, I really harp on, and you might see me go through in this talk is, I am very critical of my results. And I think if you're not as a surgeon, then you're not going to improve. So, this is kind of the thing I go through. You operate, and I think it takes used to this, but you operate, got to get good pre and post-op pictures. I get pictures of all my markings. And then go back and look at them and see what you can change. This is what I do. And this takes time, right? You look at your 6 months, your 1 year, and you see how things change, and then you start changing after that. So I think if you don't do that, it's tough to improve as a surgeon. Going through some females, and I've got some videos here about markings, and we'll try to go through those relatively quickly. So here, we marked this lady's mastopexy, and I'm getting ready to mark her upper back lift or bra line lift. So first I mark the midline, and then the next thing I'll do is usually mark about 5 centimeters apart. So I'm marking these 5 centimeter lines here just to reestablish my lines when I'm going to put the skin back together after I perform the excision. One thing I like to point out, and I think I'll say it in one of the videos when this patient's on the table, is that 5 centimeters in one area may not be 5 centimeters in another because of the loose skin. She's not terrible in that sense, but with patients who have multiple rolls, that 5 centimeters isn't the same. So here I'm marking her bra strap and then connecting that to her IMF. And then another thing what I'm showing here is that this is a lift, right? So you're pulling up, and the upper incision almost has to be straight for the most part. And that's because that skin, the upper incision, does not pull down, but your lower incision tissue is being pulled up. And this is something, again, I learned over time. I done a few early on and marked them probably a little bit too low because I would pinch and then just mark the middle and the top and the bottom. And then my scar would not be perfectly where I wanted it to be, or it wouldn't be perfectly straight. So you really want to almost just pull down a little bit. Again, that skin's not going to come down much, and then mark that line in the bra line. And then now using a pinch test, I'm estimating the width of resection or height of resection, whatever you want to call it. So we've done that on the left side of her back. Again, I'm estimating now the kind of mid-axillary point And again, I'm demonstrating that that tissue is not getting pulled down. So you want that line, your kind of final scar point, to be pretty straight across. Sometimes laterally it can go up just a touch because that tissue will pull down. So now we're going to do the same thing on the opposite side. Again, it's mostly just a pinch test. And then you're going to connect. You can kind of use the other side to estimate, but you still want to do independent measurements on the opposite side. And then once you get them on the OR table, you'll see these lines kind of transpose. And again, she does not have a whole lot of excess skin. And in those patients, it makes the marking process much more tricky. But when I start to draw those vertical 5 centimeter marks, you'll see I kind of pull that skin taut so that we can put the lower tissue on stretch. So here's the mid-axillary line. That's ideally where you want to try to get to your closure on the posterior side before you flip and close the anterior side. So I'm going to put that tissue on stretch. We're going to draw up our vertical lines. These are our realignment marks. Again, this will all be verified in the operating room. And one of the worst complications you can have is not being able to close. But on the other hand, you also, not that it's a terrible complication, but you don't want to leave too much skin behind and then have to go back and do a revision.
Okay, once you put a patient prone, all the lines shift. So I marked these purple lines here just to reinforce the red lines I had shown in my markings video. And then I remarked at 5 centimeters with prone. You can see there is a shift. And it's important to mark 5 centimeters and do those realignment marks along the length of this scar or this incision. Because again, this length here may be different from this length. So I do it on both the top and the bottom limbs. The next thing we're going to do is test our width of resection. So I'm going to take this. And that's pretty easy. I may even take a little bit more, as you can see here in my towel clamp. That's a really easy, generous resection. And then I'm going to readjust my marks, and then I'm going to inject some dilute epinephrine into the skin and then do the resection.
So the point I was trying to make, if it wasn't clear, is the purple lines were the red marks we made in the pre-op area, but you see once the patient's laid on the table, the tissue falls laterally. So I've just redone my realignment with the black pen to kind of illustrate that point. And then again, very important to test with a towel clamp before you commit to the incision lines, because some commit to one and then dissect down. I generally like to commit to both at the same time.
Okay, once you put a patient,
I don't know why those keep repeating.
Yeah, so we've taken our skin off. What I do is reapproximate all this. I did inject some Exparel to help with post-op pain control. I know not everyone has that, but we're lucky enough to have that in the hospital. My top clamp that, I'm going to use a Stratafix quill to close the deep layer and then a V-lock to close the superficial layer. They're both barb sutures. And then we'll flip it over and do the back. And this part here, past my posterior axillary line marking, I'm just going to staple because I'm going to resect that on the front. Yes.
So you can see I've gotten to my mid-axillary line in terms of a resection. Past that third towel clamp at the bottom there, we're going to staple that and then re-excise it once we flip her. But you can see how the realignment marks come together very nicely.
Yeah, so we've taken our... So we finished the upper back lift. You can see the scar is straight, the resultant scar is straight, and then the staying tissue cones at the end, we've stapled. We're going to flip her over to the front, and we'll take that off on the front.
So now we flipped her, and she was consented for a dermal suspension parenchymal shaping mastopexy, as described by Peter Rubin. So we flipped her. I've done my deepithelialization. That's the most tedious part of all this.
So we've deepithelialized the entire central pedicle. We have started raising my flaps here. This will come and rotate up around the central pedicle. The lateral flap will come and rotate up on the lateral side, again, around the central pedicle. We're going to raise kind of a mastectomy plane all throughout the breast, reshape it, and then bring the skin back over. And we'll show a quick video of that. Thanks.
And so this patient happened to be a dermal suspension mastopexy. You can blend into a reduction. You can blend into a typical mastopexy. I'd say OG, but generally as patients, if they're getting an upper back lift, they're getting more than just an OG.
So we've reshaped the breasts. We've sutured and anchored the central pedicle, lateral pedicle, and medial pedicle up on the periosteum. And now we'll redrape the skin. I'm going to go on to the other side, do that side next to make sure everything's even, and then we'll close, and then we'll bring up the nipple through the cookie cutter. So we've reshaped. So we've redraped the skin. We've made the hole for the areola. One of the things I like to point out is when I'm doing an arm and a breast at the same time, I always like to do the breast first. That way I can get my lateral mastectomy flap or breast flap over. As you can see now, my marking was pretty wide here. I may not be able to get all of that, so I will readjust that before moving on to the arms.
So very important point, and I don't really show the brachioplasty in this talk. Like I said, I think it would have been too long, but we will show her pictures. So this is what she looks like on the table after everything's complete. This is her 1 week post-op. I think this is the video.
So on a week post-op was day 7. She had a better reaction to the glue, as you can see by some of the redness here. But otherwise, everything is looking pretty good. Moving along to the back. Again, that redness is all just a little bit of glue irritation, a little bit of bruising in the abdomen where we took that, did some liposuction. Otherwise, everything is looking very good.
So here's her pre-op, like I said, my markings, and then her 1 week post-op result. Same thing from the side. The Band-Aids here are where we took her drains out at that first visit. I don't believe she actually developed any wounds, although it's pretty common to get it at that T-point on the lateral chest. Again, pre-op markings and post-op. You can see I tried to line up her shoulders and her trunk in exactly the same spot. And you can see pretty clearly that her ended up exactly where that upper marking was, where we made her top incision. And everything is getting lifted up as it should be. Same thing for the arms. And again, a point that you really should do your breasts before you do your arms. And then you can adjust your vertical resection on the lateral chest after you've done the breast lift. And here's a side photo. Again, that's her drain site. All that redness there is just a reaction to the glue, so we ended up peeling it off at her first post-op appointment. Here's some more examples. This is a patient pre-op marking and post-op. In her first stage, we did her arms and a lower body lift, and then this is the markings of her second stage. Again, another dermal suspension, parenchymal reshaping. If you're not familiar with that, I would point you towards Dr. Rubin's article back in 2006 where he described it. I think it's a great article. And then we did an upper back lift at the same time for her. This is her back lift scar. This was an early result. You can see the scar is still in her bra strap. If you look right around the scar, you see the indentations from her strap, but the very central portion is a little bit high. And that was a mistake on my part early on in my career when I do these upper back lifts, or when I did her upper back lift at least. I needed to take additional tissue in the center. You can see it really narrows to a very small point centrally in my markings. And rather than take it from below, I took it from above on the OR table. So again, I should have stuck to my initial pre-op marking with the upper incision, and if I was going to remove more tissue, I should have taken it from the lower part of the back. But you can see the powerful shaping of the flank and side that this operation can give patients. Here's her T-point. I believe she had a wound on one side, but you can see how that arm scar blends very nicely into the lateral chest upper back lift scar. Just different views, same patient. Here's another example. I believe she was a traditional mastopexy upper back lift. She actually staged this. I can't remember exactly why, if it was financial reasons, or maybe didn't think she needed the back lift and then came back and had it. But this is the anterior view, and then anterior and posterior view. She had a bit of widening here in the central back. We've offered her a revision, and she's happy with her results, so she never came back for it. Here's her profile view. Another patient, a little bit more challenging. This patient wanted a mastopexy, but wasn't exactly a great candidate in my opinion. Didn't have much tissue, very asymmetric. So we actually did some fat transfer to her breast. So that's the pre and post-op of that stage, along with lower body lift. We came back in a second stage and did a mastopexy. So those are the markings. There's her post-op result. And then we came back a third time to do a little bit of a revision and add some more fat for volume for her. And so those are her markings. And then here's her post-op result. And we did an upper back lift at the same time. And again, you can see the difference it makes in the flank area and some lipo of the lower body. We'll go through more examples. So again, pre-op markings, and then markings and post-op. Again, same thing. You can kind of see the outline of her bra there, and you can see that's exactly hidden by the scar. Probably a little bit too high centrally. Again, this was an early result. Again, learn from my mistake. Make that line straight, and then just lift everything. That upper line will not move. Patient, so she had breast reduction, upper back lift, and brachioplasty. Another patient, again, staged. She'd had augmentation elsewhere, I think with a lift years and years ago. So we did a breast revision, implant removal, mastopexy, and then upper back lift. And you can see, again, nice shaping of the flanks there. Here's one more breast reduction, upper back lift. Again, you can see that scar is right in line with her IMF. This is one where if you're not doing an upper back lift, I think one of the nice combinations, and I learned this at ASAPS from another colleague who does a lot of body contouring. If you look at the middle post-op photo, rather than traditionally, I used to make almost a straight line down and then an L shape or a very corner type incision. But when there's no up, I started to, I picked up this technique from someone else and started curving these scars. I think it looks much better and kind of rounds out the breast nicely. So you can see that in the lower middle picture. So again, combining brachioplasty with breast reduction. This patient, we did more of a breast lift and then some liposuction and Renuvion of her back. She did not want an upper back lift scar. You can see she doesn't have deep set rolls, and that's acceptable for her, but typically not something I would offer, a massive weight loss patient who's lost 100 pounds or so. Here's another example. Stage 1, this was after 2 stages. Her first stage was a mastopexy, reverse abdominoplasty, and brachioplasty. And that's why her scar goes all the way across the middle. That reverse abdominoplasty we used to remove this kind of double roll she's got on the upper abdomen. And the second stage, we abdominoplasty. So again, that can be safely combined. She's probably someone I would have done an upper back lift on. But I think she's 22, 23, didn't want that scar. So we came back in her second stage and did some liposuction and Renuvion of her back. It's an okay result. She's happy. We both think she'd gotten a much better result if we had done a back lift, but sometimes you have to do what a patient wants. Don't need to go through these examples. So in males, similar ideas. We don't wear bras as men, so sometimes the back lift is a bit of a hard sell, and you've got to get creative. So this guy was excision of gynecomastia. Again, didn't want a big scar, so we did liposuction with Renuvion of his chest. For this gentleman, he actually wasn't too bothered by his chest tissue or the gynecomastia. What he really disliked was that lateral chest roll. And so for this gentleman, we did what I call a torsoplasty, a lateral chest wall excision. So you can see his scar pretty much stops right at the nipple level. And does not go medially, and obviously the chest tissue is still there because that wasn't his goal. But we excised along his outer chest this large roll of skin here. I think this is going to be my last example, and one of the things I learned a lot from was this patient. He was someone who'd lost 400 pounds, had multiple previous abdominal surgeries, and came in for contouring. He was a very high-risk patient. We did his gynecomastia excision along with an upper back lift. And I had staged him. This was his second stage. I had done a lower body lift previously. Again, with him, there's no other solution. If you look at his pre-op, he's got extensive skin rolls after losing 400 pounds. But one of the things I learned from him was to do my lower body lift first, because if you look at that scar, so now we've enlarged that. I think by doing his lower body lift first, I set the scar maybe a little high then, probably not in the best location. And then when we came into the upper back lift, we raised that scar a few centimeters, and now it's totally out. So that was an early lesson learned for me. So things I've learned, and I can impart hopefully to some of you. Set your anchor line when you're lifting. When things are lift, you want to set your anchor line up top, and then you want to estimate your line over section. You can always take more intraoperatively or less. For body contouring and lifting, it's more predictable when you're working from top to bottom, especially the more weight loss a patient has had, kind of like the last example I showed. I think when patients are heavier and still have a lot of adipose tissue, it can work better the other way around, because you don't want the weight of that tissue kind of pulling down on that upper back lift scar on your buttock scar. So you might want to work backwards from bottom to top. And then patients who've lost a significant amount of weight, 100 kilos or more, I think they're the toughest. I think they require more planning. And in my experience and in my hands, I tell them they need more stages, and or revisions to get the best results. So thanks for listening, and I'm happy to answer any questions.